I'm really delighted to be able to chair this particular session where we are hoping to follow up with the very good presentations we had prior to the coffee break, but to really get into some of the details and also some of the issues that has really confounded both developing countries and the development community for a number of years in this particular area. On our panel, I have from my left, Krzysztof Kurowski, World Bank lead specialist working currently in Eastern Europe with extensive experience also in Latin America. Fole Royer from Hygears, he's the CEO of one of the HMOs in Africa, one of the more prominent HMOs in Africa, and also a provider, a hospital and primary care, so a real practitioner from the field. Mr. William van Druin from Acmea, the CEO from Acmea, who's very active also, both obviously being the head of an insurance company here in the Netherlands, but has also in his capacity as a board member of both the International Federation and also the Dutch Health Insurance Fund, has really had a very extensive contact with some of these issues from the perspective of a Dutch insurer and seeing things from both sides of the fence. So we're really delighted to have you here as well today. And then finally, my colleague Kamarogo, who heads up the Health in Africa initiative for the World Bank. It's a billion-dollar initiative with about $500,000 in debt, 300 million in equity, and 200 million in technical assistance facilities, which is set up basically to look at new and innovative ways to work with the private sector and facilitate a development process which is different from the past. So without much further introduction, I just want to say that the way we want to conduct this particular session is that we want this to be a debate, so we are going to discourage speeches or long presentations. We want to have this debate around some of the issues that were really put on the table very well during the morning speakers. The name of the session is Health Insurance, Weak States and Resource-Poor Settings. I want to keep the focus on that topic because I know it's easy to drift off this topic a bit. You have the divide of the English Channel in this debate where very easily you drift into a debate of insurance versus non-insurance. And I think we want to look at obviously non-insurance things, but this discussion here is about insurance. How can you make insurance work in these kind of contexts? So we don't want to drift too much into too many other issues that are important issues, but it's not what we are trying to do in this particular session. And then I want to highlight, maybe in framing the debate we're going to have, I just want to highlight 6 things I think we need to be thinking about. One is design. There's a whole bunch of discussion about micro versus macro, private versus non-private, for-profit, non-profit. So we need to touch on this issue. This is a very important issue when it comes to insurance. And it gets very confusing because it gets very confusing when you talk about public versus private mandated insurance. A second issue is the whole issue of whether or not you can leapfrog. It's fine when we've heard the issue of, there's been experiments in Africa, but there's also large experiments in India. Can you actually leapfrog? We're in the 21st century now. Can we bypass the course of the last century, the experience we've had in Europe, and really just jump to the end point? This becomes extremely important, I think, in terms of the inheritance that many countries in Africa have, where they inherited often a colonial system and then had to move forward. Capacity and institutional underpinnings is really important, and there are the issues of whether or not there are preconditions. 5-6 years ago, we would have said there are preconditions, don't touch health insurance in Africa. I think we're in a very different space today. These preconditions have really been blown out of the water. We now have several African countries that are doing this, and what would have before been constraints on preconditions now actually don't exist there anymore. Or the preconditions may still exist, but we know that things can happen without preconditions. And then the 2 final things is really the difficult issues, and I'm very glad that we have in the audience here people who are from the political side of things, because I think in the health insurance, when I give talks on health insurance, I often say health insurance is 97% political, it's 3% technical. If you get the politics wrong, you're not going to have health insurance. So I think, really putting this thing solidly on the table, that there's a political dimension here, becomes extremely important. And then finally, we heard this very depressing discussion from my former colleague, Jacques van der Haag, about what we're doing with our donor money. I don't want this debate here to be dominated by this, but it would be a shame if we don't have some word about how we're wasting our donor money, at least by the end of this session. So we want to come back to that issue as well with the panel. So the way we're going to do the panel now, I'm just going to ask each of the panelists to introduce themselves very briefly, a quick 2-3 minute just overview, just what you do and why you think this topic is important to you. And then the details of what you might want to say we'll draw out as I go through these points of discussion that I've just outlined. Why don't you start, Karma, on the right-hand side?
Thank you very much. Thank you very much, Alex. Highness, distinguished colleagues, I work with the World Bank Group. I had a special initiative called the Health in Africa Initiative that is helping African governments engage better with the private sector, recognizing the private sector is already a provider of often more than 60% of healthcare and financing more than 50% of the finances. And yet this has not happened in the 60 years that our countries have been independent. Public and private have seen themselves as enemies, even an area where collaboration would have been the essential thing to do. Our approach is through 3 main work areas. Analytical work. We have provided information for the private and public sector for them to realize why they must work together and what the gains are. We have work on policy and regulatory areas, and I'll show you why that is important, because most African countries still, in terms of health and insurance, are relying on pre-colonial laws and regulations that just can't work today for what you want to do. And thirdly, in the area of investment, that includes direct investment, investment from the people themselves, from outside, insurance, and others. That is where I work. But for the purposes of this discussion, I will put down my World Bank hat because I want to be combative, and that will restrict me. So I will tell you things that I think must be done appropriately and now in Africa for us to be able to move forward. And 3 things that I want to put on the table. One is that there are 3 major gaps that we have to address in the area of health insurance and access to care in what we are calling weak states. One is the whole area of financing. Where is the money? Who has the money when? And what is it being used for? If you look at the data, then you will show that the most important money giver to the health sector in these weak states is the individual, that very poor person that we keep referring to. It's not the exchequer, it is not the donors. And yet when discussions like this take place, they're never on the table. We talk about them and for them, and their voices are not there. Secondly, there's a gap in service delivery. It's not about having the money. It's not about being insured. People are not proud because they hold an insurance card. It is, do they get the care that they've been promised when they have that insurance card? That gap is important for us to work on, and the quality of it. And third is a gap in regulation and policy. Because where is your protection? I come from a continent where we've seen HMOs fall, fail, and go bankrupt with people's money. There is no protection anywhere. Where is the accountability? Who is taking care of this? And on top of that, I want to try and cover it with one area, which is the area of trust. When we talk of weak states, weak for what purpose? The big problem we have in our countries is trust, trust, and trust. When a government tells you that population, don't go to that corner because there's a bomb that's going to blast in a few minutes, people run there to see if there's really a bomb. So who do people trust with their money? Is that why we go micro, or is it because of another reason? And most important, the dynamics that are changing in Africa. Today in Africa, it's no longer the Africa of 10, 20 years ago, where the Minister of Finance is some semi-literate military man. Go to Nigeria, it's Professor Chukwu. Intelligent, knows what he's talking about. Go to Zambia, it is Professor Kasonde. You can't get better than that. Come to Kenya, it's Professor Nyong'o. These are people that can now sit here and debate with you. So even as we go there, know that you're going into a different continent. Weak state maybe, but not weak in mind and intention.
So this once again highlights the capacity misconcept that I think we now have to overcome in our thinking as we look at both solutions in Africa and other countries. Yes, please.
Royal Highness, ladies and gentlemen, good morning. I'm representing Achmea, which is a mutual and cooperative insurance group in the Netherlands. We were founded 200 years ago as a cooperative, founded by farmers. As we always say, it's kind of a romantic story, but I will be brief today. But very important is that Achmea as a health insurance group, we strongly believe in solidarity and in social involvement. And we also believe that community-based mutual insurance can play an important role to create access and affordable health care in developing countries. At the same time, we need to be very modest as an insurance company. That's also why we try and intend to play more a role on the background and to try to support good initiatives, because we have learned that there is not a, let's say, a blueprint you can use in other countries. If you look at health insurance in the Netherlands, and you could think you can make it work elsewhere. Even in Europe, when I was responsible for the European health insurance activities of our group, one day I thought I start to establish a pan-European health strategy. And that turned out to become a big deception, because there is not one strategy. You know, at the best you can have one approach, and there are certain countries who have comparable issues which we can use, but I strongly believe that you have to look at each country on an individual basis. But at the same time, in insurance, there are some, I would say, basic principles which are more or less universal. We can talk about it a little bit later. We as Achmea also decided to support microinsurance for many reasons. One of the reasons is it's very close to the identity of the group, because we are a cooperative, we are a mutual insurance group. And the other reason was that Her Royal Highness Princess Maxima once opened a new office building of our group, and then she already became a big sponsor of microfinance. And actually she made us volunteer to do something in health microinsurance. So that's one of the other reasons. But I think it's important that a large financial institution in the Netherlands, in a climate where the climate in the financial markets is very rough, I think it helps within our group, and it supports our identity, and it motivates people to put effort in these kind of initiatives. So there are actually basic reasons why we are involved. And if you do so, I believe you need strong partners. So especially when you are entering a world in which you are not familiar, we found out that partners like Farm Access and Health Insurance Fund, but also HealthNet TPO and the Daan Foundation are very important for us to create sustainable collaboration and a sustainable insurance platform in these, what I would say from an insurance perspective, difficult countries. Not only our group is involved, I've seen other examples, for instance, established by Kaiser Permanente, a large American health maintenance organization who did a lot of work in Uganda and quite successful. So we can also learn from them. There's no blueprint, I said, but there are a few things I believe are important to have to create in order to be able to create a sustainable health insurance system. Insurance needs a regular cash flow. So what you need is an approach where insurance is part of an integral plan, where we focus a lot on reducing vulnerability of low-income people. if that's not in place, there is no cash flow. There will no premiums being paid. So I don't think then you can create a sustainable system. There's also a strong link between food security, health, and insurances. At the other end, vice versa, micro-insurance can also trigger food security and support that. It's not by law, but I also feel that insurance products provided and affordable can be more successful if they are delivered in a mutual or a cooperative system, because then you create ownership of the members. It's not the only way, but I believe it helps. And finally, Chairman, I would like to say that for us, health insurance is not a matter of charity. I strongly believe in public-private partnership with ownership of the members involved. And these people must feel that they are part of the system and they can control. And then, above all, it's all a matter of trust. So find partners you can work with on a long-term basis. Thank you.
Okay, well, thanks very much also for that those opening reflections. Once again, you're highlighting the capacity sustainability issues. So we'll come back to those in a few minutes.